This is posterior uncoverage. So the lateral looks fine. So there is the posterior wall. If you did the LCE angle from this posterior wall alone, it'd be like 2. Right? You want this posterior wall to be going like this. You want to, if you play basketball, you want a backstop. All right? So this is not enough coverage, enough in the front, but not enough in the back. Here's the classic anterior lateral, just not enough coverage three-dimensionally. And here's where you have combined version, where you have femoral anteversion, acetabular anteversion, and we needed to treat both. Or what we see more and more, iatrogenic instability. So the capsule's not there, the rim was altered, and now we have an unstable hip. So here's how we measure the lateral center edge angle. Circle around the femoral head. We want to create a perpendicular. And then we measure right there. And we know anything under 25 has a potential for osteoarthritis. We now measure acetabular depth, which is the lateral sourceal to the symphysis. And this, the widest point should be greater than 9 millimeters. The prognosis is bad if it's less than that. Tonus coverage. This is the tonus angle, which is the sourceal, the eyebrow angle. It should be under 10 or 8, especially for hip arthroscopy. If it's above 15, those hips fail. So look at that as well, and also percent femoral head coverage. So there's a lot of different variations you can do. We're trying to train AI now to do it for us, and then look at prognosis outcomes. So that's the tonus angle, and this is the depth to width. There's some other angles called, acetabular. This basically is a percentage of how much anterior wall covers the femoral head, but that's not as critical to do. You can do the false profile, which measures, do you end it here? This measures kind of the anterior lateral aspect of the hip. So again, LCE less than 25, tonus angle greater than 8, femoral head coverage less than 80%, or decreased acetabular depth. This is dysplasia. Okay? So on initial evaluation, you need to do history, observe gait, supine hip motion, supine provocative maneuvers, prone range of motion, and radiographs. And I'll go through this. So dysplasia symptoms: activity-related abductor fatigue. It hurts when I sit too long. It hurts when I stand too long. For females, wearing heels is harder. Okay, so sitting, standing pain, kind of some days are bad, some days aren't. Usually, this is a quote, it hurts when I sit too long or stand too long. And so many patients say that. Okay? The natural history of dysplasia is worse in females than males because of the ligamentous laxity, the pelvic shape. Okay? So here's the gait evaluation you do on patients. Okay? I think everybody would agree. This is an internally rotated gait. So you can do that because you have femoral anteversion or because you're trying to stabilize the hip. Those are the two reasons. Okay?
Tell me when.
Go ahead.
So then I check for hip flexion and internal rotation. I'm not pushing too hard to see if it's irritated. Okay? So natural hip flexion is not 120 or no 130 because then you're just moving the pelvis. So you go slow till you feel an end point, and that is the hip flexion. Probably everybody in this room probably averages about 95. Okay? It might be greater in anteverted hips. And then, so I do flexion, then in extension, I do internal and external rotation, and then in flexion, I do internal and external rotation. Okay? So here is the impingement test. Look, she's not flexing. Look at her face. She's not happy with that. She's impinging.
Hurts where?
She doesn't like that motion at all. And much better when you externally rotate it. This is something we came up with called the part test, where we extend the leg and push down.
Okay, I'm going to push. Ready?
And this person has pain in the front of the hip.
Yeah.
And we found that positive in about 30% of our anteverted hips. So that's another test to do. And then prone, you can check your range of motion as well. So here's acetabular anteversion, where you can see the anterior wall is minimal. CT shows under coverage in the front. This is not an impinging hip. This is from instability. See anterior wall, posterior wall, and not coverage. So that's the kind of hip where you'd have the positive part test. Prone, extension, push, it may hurt in the front. Here's the posterior instability test where I flex adduct and push posteriorly and they have pain in the back, that might be more like this hip, which has anterior wall, looks pretty good, right? Covers the femoral head. Posterior wall straight up and down. So there's there's posterior lateral instability, okay? Which might impinge in the front and may be unstable in the back. Okay, non-spherical femoral head. This is an issue. It's flat here, and that's from a ligamentum teres that's hypertrophied and they're unstable. So for DDH, the summary is increased hip flexion. They're not impinging. They're anteverted. You can flex it pretty far. Increased internal rotation from usually femoral anteversion and no anterior coverage. Apprehension test, which is externally rotated. Extension, they have pain in the front because you're exposing the front of the femoral head. Or the part test, which is prone pushing. Okay, and soft tissue laxity, which is very common. So to summarize for the exam, I have them walk, lay down flexion, flex the hip, internal and external rotation, look for impingement, look for apprehension, and then place patients prone, check their internal rotation prone, and check the part test. Does that summary exam, hip exam, make sense? And then sometimes we'll get an MRI, which looks for cartilage, or the other day we found a stress fracture. So even if you're consistent with a diagnosis with CT, the MRI can sometimes show you other things, and such as labral hypertrophy, iliocapsularis hypertrophy, or a high fovea position. The CT scan is valuable in mild cases. Now we do a CT scan on every operative hip to make sure we're making the right diagnosis. Okay, too much head showing. So this is, obviously when you see the fovea, you know it's instability. So mild and borderline cases is a factor in development of OA. Prognosis is worse in females. The diagnosis can be complex. Analyze factors such as prior treatment and utilize different modes of radiology. So if they're dysplastic, they failed conservative treatment, then we will do non-operative treatment first, and then we will do the periacetab or osteotomy, which I'm happy to talk to anybody about in the future. We kind of went out of time here. But this is the best thing that we can do, I think, to support the hip. We do an extra-articular osteotomy now for more than 30 years. It balances the cartilage over the femoral head. So you're increasing the surface area of the cartilage. That's the goal of the PAO. You can also make sure your anterior and posterior wall version is normal and it maintains the abductors. So it is a big surgery, but it is effective in about 90% of the patients. So this is what it looks like. So now we can do subtle corrections through small incisions that you would do a similar incision to a total hip, but more we do transverse versus longitudinal. And here's the example as I'll whip through because of time. We're doing the osteotomy in a very controlled environment, and repositioning it
Internal
and
rotation?
putting it where you can see anterior,
External
posterior
rotation.
walls, femoral head
Internal?
coverage. Look how mobile that thing is.
External.
Okay, you can put that wherever.
Good.
When you get to that point where it moves, you're like, oh, good. Now we analyze. Does anybody use do total hips? Do they use navigation at the end to tell where it is? So we now can measure all these indices inter-op, which tells me exactly where the hip is, which I think has been a big factor and has really helped. How do PAOs do in the long term? Early, they can get back to sport, and fortunately, the risks are minimal, but you always have to think about sciatic nerve palsy, non-unions, interarticular fractures, and sometimes we'll do a hip scope at the same time. Okay? Any questions about all of dysplasia?